Good morning, everybody. My name is Guerra, and in this module, I will present to you the European Risk Management Plan. In this presentation, I will give you a short introduction of the Risk Management Plan, the structure of it, the points to consider about prophylactic vaccines, and at the end of the presentation, I will provide you a practical example of RDSS, the malaria candidate vaccine that was recently approved by the EMA. The Risk Management Plan is a regulatory document required within the European Union for any new marketing authorization application. It can also be imposed to products on the post-marketing phase if new safety concerns are identified. The Risk Management Plan will describe what is known and not known about the safety profile of the product. And this is because at the end of the clinical trial period, there is limited information on the safety profile of the product because the inclusion-exclusion criteria used in clinical trials, the small sample size population on the clinical trials that makes difficult to detect rare adverse reactions, the short duration of the clinical trials that would prevent the observation of adverse events with a long latency period, and especially because the population of the clinical trials doesn't reflect the population during post-marketing period. Therefore, the Risk Management Plan will describe the important identified and potential risks, as well as the missing information. The Risk Management Plan will provide the pharmacovigilance activities and interventions designed to identify, characterize, prevent, or minimize risk related to the medicinal product. It describes post-authorization effectiveness studies and the measures or minimize risk associated with the product. This is all done to ensure that the benefit of the product will outweigh the risk. The Risk Management Plan structure consists of 7 parts. The first part is the product overview, which is the administrative information about the product. Part 2, which is the safety specification of the product. It's subdivided in 8 modules that provide information on the epidemiology of the disease, information of non-clinical studies that have been performed, information of the clinical trials that have been performed, information of the population that has not been studied in the clinical trials, also some post-authorization experience if the product is already authorized in another country outside of EU. All this information will lead to the identification of risk. Important identified risk, which means risk that have adequate information of causal association, and important potential risk, which there is only a suspicion of an association. The key word is important because we don't want all the adverse reactions that have been seen in the clinical trials to be put in the Risk Management Plan. Important risks are those events that can impact on the benefit-risk balance of the product, and this could be risks that have impact on the individual level and risks that can have an impact on public health. The part 3 is the PV plan. This is the section which describes the PV activities for each safety concern. The PV plan could be routine pharmacovigilance activities, and it could be additional activities, for instance, PAS or post-authorization safety studies. A single safety concern can have no additional PV activities because routine is sufficient, or can have one or multiple studies. It is important to notice that the protocols of any study should be submitted as part of the Risk Management Plan and clear milestones should be provided. Part 4 is the section of post-authorization efficacy studies. For many medicines, this is not necessary. However, there is a potential need for certain medicinal products, for example, therapeutic medicines and vaccines. Part 5, which is the risk minimization measures. There are routine risk minimization measures like the labeling or SMPC, and there are additional minimization measures that is whatever goes beyond that and should be proportional to the risk. Importantly, the effectiveness of these activities should be measured and should not be promotional in nature, and should have clear addition of what is mentioned in the product information. Part 6 is the summary of all of the above and any major changes of the risk management plan over time. Part 7 is the annexes, protocols, for example. Something important to mention is that a risk management plan summary must be publicly available. Probably you have received the summary of the risk management plan for RTSS together with this presentation. There are some points to consider regarding the risk management plan for prophylactic vaccines. Two terms are relevant to vaccines. One is the adverse event following immunization, IEFI, which are defined as any untoward medical occurrence which follows immunization and which does not necessarily have a causal association with the use of a vaccine. And we have 4 categories apart from the coincidental event. First, vaccine product related, an event that is caused or precipitated by a vaccine, for example, extensive limb swelling following DTP vaccination. Second, vaccine quality defect related, due to quality defects of the vaccine, for example, failure to completely inactivate a batch of inactivated polio vaccine that could lead to cases of paralytic polio. Third, immunization error related, caused by inappropriate vaccine handling. Fourth, immunization anxiety related, arising from anxiety about the immunization. An example of this is syncope, mostly in adolescents. The second term is lack of efficacy, because lack of efficacy for vaccines is considered to be a safety issue, and this has to be monitored. Lack of efficacy is the occurrence of the specific vaccine preventable disease in a person who is appropriately and fully vaccinated, taking into account the incubation period and the normal delay for the protection to be acquired as a result of immunization. For example, the occurrence of rotavirus gastroenteritis more than 2 weeks after vaccination with the second dose of Rotarix. Other specificities of vaccines are shown in this slide, but I would mention some of them. Vaccines are provided to healthy individuals, mostly young and vulnerable subjects. Casualty assessment may be difficult because multiple vaccines are administered at the same time and many diseases developed at the same time of vaccination. The benefit-risk balance also depends on factors at the population level. For example, the benefit-risk balance of Rotarix vaccines is different in EU compared to Latin America. In EU, vaccine will avoid hospitalization due to the gastroenteritis by rotavirus, and in Latin countries it will avoid deaths due to rotavirus. The public perception may impact vaccination programs. For example, the postulated link between MMR vaccination and autism in '98. It became a major public health issue in the UK, where the coverage dropped dramatically and later outbreaks of measles and mumps occurred throughout the UK. The benefit-risk balance is dynamic. This is because if the disease incidence decreases but the risk remains at the same level, for example, with polio and flaccid paralysis. And usually, vaccines are provided through vaccination programs, where thousands of people will be exposed to vaccine in a short period of time. In this slide, you can find the specific consideration for prophylactic vaccines in each section of the RMP. For example, in Part 1 of the product overview, it is important to mention the type of vaccines, like viral vaccine, inactivated vaccine, or recombinant vaccine, as well as the delivery system, vectors, for example. On Part 2 of safety specification, it is relevant to know if there is residual proteins that may have a structural homology with human proteins, the potential for transmission of infection diseases, like shedding, the risk of medication errors, breakdown of the cold chain. On Part 3, on the additional PV activities, we have epidemiological studies to detect strain replacement. Part 4 of post-approval efficacy studies is where we get additional information on waning immunity, long-term protection, cross-protective efficacy, effectiveness, and impact. Part 5 is for the risk minimization measures and where we can add appropriate communication to avoid medication error. Let's move to a practical example of a risk management plan for RTSS, the malaria candidate vaccine. RTSS is the result of 30 years of extensive research in collaboration with several partners. The result of this large clinical development program was obtained last year when the European Medicines Agency, EMA, adopted a positive scientific opinion under Article 58 for RTSS. Over the first year of the clinical trial, RTSS reduced the number of malaria cases by half in children and by a third in infants. Vaccine efficacy was highest shortly after vaccination, but could be enhanced by a fourth dose. Efficacy was demonstrated on top of high usage of insecticide-treated bed nets, and RTSS AS01 has been evaluated in clinical trials in more than 11,000 children, and in this table we have the adverse reactions included in the product information, and those are similar to other pediatric vaccines. Based on the benefit-risk profile, RTSS was recommended by EMA for active immunization of children 6 weeks to 17 months of age against malaria caused by Plasmodium falciparum and against hepatitis B. In the label, we have also specified that the use of RTSS should be based on official recommendations. The use of other malaria control measures should not be interrupted. RTSS should not be used for the prevention of hepatitis B in settings where prevention against malaria is not sought. However, the WHO recommendation provided by SAGE and MPAC was different from EMA. In effect, WHO recommended a pilot implementation of RTSS in young children from 5 to 17 months of age to assess the vaccine protective effect when administered outside of the clinical trial, so in real-life settings, to ensure the feasibility of 4 doses outside of the vaccination schedule, and to measure the impact on child mortality and to monitor the safety signals meningitis, and cerebral malaria. In this slide and in the next one, there is a summary of the safety concern for RTSS, what is known and not known about the safety profile of RTSS. So there is one important identified risk, febrile convulsion, because there was an increased risk of febrile convulsions within 7 days post-vaccination in clinical trials. And there are several potential risks. Meningitis, because a numerical imbalance of meningitis cases of any etiology was observed in the large phase 3 trial. After further analysis, the most likely explanation is a chance finding. A rebound effect, because a trend for higher rate of severe malaria diseases was observed in the long-term follow-up in children who did not receive a fourth dose of RTSS. However, the numbers are very small. And some theoretical concern, potential immune-mediated diseases because it is an adjuvanted vaccine, hypersensitivity, that is a theoretical concern for any vaccine, and behavioral changes regarding use of other malaria preventive measures. The additional PV activities for all these concerns are epidemiological studies that I will describe later. Here we have the summary of the missing information. Impact and effectiveness of RTSS, fever upon co-administration with other EPI vaccines known to induce fever, safety in HIV-infected subjects, Plasmodium species replacement and Plasmodium falciparum strain replacement, long-term efficacy, immunogenicity of RTSS when co-administered with measles and yellow fever vaccines, cross-immunization against human catalase, vaccine efficacy and safety in subjects from regions other than Sub-Saharan Africa. The PV activities for the missing information will be also epidemiological studies and clinical trials. Regarding the risk minimization measures, we consider that routine risk minimization measures are sufficient and no additional measures are required for RTSS. In addition of all the specificities that any prophylactic vaccine has, RTSS has other specificities that are mentioned in this slide. It is the first malaria vaccine. It is the first vaccine against a parasite. It's the first vaccine using a neoadjuvant in a pediatric population. Pediatric clinical trials have been developed exclusively in Africa, where the burden of disease exists. There is no baseline incidence data for adverse event of special interest, and PV systems barely functional or inexistent. Of all of that, we consider a potential sequential introduction of RTSS. What does it mean, sequential introduction? Well, first, RTSS will be introduced in countries where the epidemiological studies will be performed and active surveillance will be in place. And then, in other countries that we call early adopter countries, where we will use enhanced surveillance in order to monitor the safety of the vaccine. But of course, it will depend on the WHO recommendation. In this slide, we have an overview of the most relevant epidemiological studies that are mentioned in the risk management plan. In these studies, we will collect information on the identified and potential risks, as well as some missing information. The aim of these studies is to estimate the incidence of adverse events of special interest, meningitis, death, malaria, and cerebral malaria. The adverse events of special interest are events that have been related to RTSS or have been related to other vaccines or are potential immune-mediated disorders. The design of these studies is defined as prospective cohort event monitoring, and the designs incorporate both active surveillance, and hospital-based surveillance. The first study is the EPIMAL-002 that will be performed before vaccine introduction in at least 3 countries to obtain the background incidence of the adverse event of special interest. This study will be followed by the EPIMAL-003, which will be performed after the introduction of RTSS in the same countries. Therefore, we will be able to compare the incidence before and after the introduction of the vaccine. This study will also assess the effectiveness and impact of the vaccine. Additionally, there is a third epidemiological study, EPIMAL-005, that will be running in parallel to assess the malaria transmission intensity and the malaria control interventions. In the early adopter countries, the main activity to propose to countries for the improvement of the safety monitoring of RTSS will be the enhanced surveillance through sentinel sites to detect serious adverse events following immunization, together with a capacity building like PV trainings to healthcare professionals, community sensitization for reporting adverse events, etc. The duration could be for 2 to 3 years, time to obtain results from the EPIMAL-003, or until sufficient patient exposure data is obtained to adequately define the safety profile of RTSS. It should be noticed that what is mentioned in this slide, it is a proposal and has not been included in the risk management plan because we need to discuss with the different sub-Saharan countries to identify what is required for effective safety monitor of RTSS, and they will decide which option is ideal for their local system. And this is the end of my presentation. Thank you very much for your attention.